Hello.
Hello. Hello. Concord.
Okay, that's better. I can see people. Okay, welcome everybody to today's public board meeting. I'm very sorry that we are still virtual, or we are back to being virtual again after last month's really good seminar when we were able to be in person. I'm just recovering from my second bout of COVID, and I know that many other people are similarly affected, which is the reason why Matthew and I decided it would probably be better to do this virtually. But I'm very hopeful that we'll be able to be back in person again soon. Welcome to some people who are attending their first public board meeting today. Mamta Vadia, who although has been with us for some time and is already making a very splendid impact, this is actually her first public board meeting as Chief Medical Officer. So welcome to Mamta. Welcome to Fiona Wheeler, who's attending the board as Programme Director for Planned Care. And welcome to Roberta Hook, Operations Director for the North East London Adult Critical Care Network, who's observing the board as part of the NIBEVN programme. You're all very welcome. So shall we move on to item number 2 then, that is the patient story. And Victoria, I think you're going to, oh sorry, Mamta, you wanted to say something.
Jackie, we've got,
So I'm Sarah Dunton, I'm Director of Nursing Care representing Catherine Halford. And I've been asked to introduce Anna Page, who's one of my Director of Nursing colleagues, who's quite new to the Trust, and she's the Director of Safe Workforce. Sorry to jump in there.
I was actually going to come to that, but you're very welcome as well. You're very welcome as well, Sarah. Okay, good. Victoria?
Good afternoon, Chair. So slightly different this meeting in terms of the patient story. So at the June Patient Experience and Engagement Assurance Group, we asked all the divisions to bring patient stories that they wanted to share and the relevant learning from those. And it was a really, really good meeting and everyone got a lot out of it. There was lots of learning shared. Most people chose to bring good stories, as you would expect. But there was a story that really resonated with a lot of people. And so today I'm going to ask Ruth Dando, lead nurse for critical care, to share that story. It's not appropriate for the family to come at the moment. They're going through some stuff. So I've asked Ruth to come along and do that. It might sound like quite a negative story, but she was very brave in being the first person to actually tell a negative story on that day. And there is a lot of learning that she's going to share from that. So I'll hand over to Ruth.
Hello, good afternoon, and thank you for listening to the story. That it really struck a chord with me when I first read this email from the daughter of a patient that had died with us 3 months previously. And the thing that made it quite significant was the fact that it was very balanced. And she voiced, it's not a complaint, it's about she wanted to gain some understanding and she was struggling with some questions and queries that she had. So I obviously undertook an investigation to look at some of the concerns she had raised, and I found it very sad, my findings, because they were not as I would have liked to have perceived that the care that we had delivered to this lady had been. She was, just a little bit of background, she was an 81-year-old lady who enjoyed a relatively good quality of life. And she had a brain tumour, and it was decided to remove this tumour. The complications and risks and benefits were highlighted to the patient and her family, and they took the decision to go ahead with the surgery. So obviously what that was initially an issue that could have arisen for the family, and the fact that, you know, questioning did we make the right decision for her to go ahead and have the surgery. So there's a lot of guilt and difficult feelings for the family based on that as a starting point, because obviously the outcome wasn't as they had hoped. Unfortunately, she had a immediate post-operative complication. In fact, that when they tried to wake her up from the anaesthetic, she wasn't waking up as we would expect. She had the breathing tube taken out of her throat, and that needed to be replaced, but initially just a temporary tube was placed and the patient was moved to our post-operative care unit at King George's Hospital. There was an issue around this patient transfer because the fact that they used just an airway adjunct as opposed to a formal breathing tube, and the patient was moved before she'd had a scan of her brain, was probably not the right order to have done this. So we looked at that as an incident around what we could learn from that at the time, and basically she should have been stabilised with a proper breathing tube, and she should have had a scan before moving to intensive care, because it did show some post-operative bleeding in the brain, and that obviously would have been a problem that we couldn't avoid, but we could have picked it up a bit quicker. She was the outcome though of that incident review was that there was no harm occurred to the patient as a result of it happening, and it wouldn't have affected or impacted on the outcome that this patient ultimately had. But we definitely found there was some learning to pull out in terms of transfer of patients and their care of patients in recovery out of hours. So the next day we moved her to King George Hospital, because obviously we have our specialist neuro ITU. And it was very clear this is not going to be a quick post-operative recovery because of the complications that had been occurred. So she remained on a breathing machine and sedated, and every day we would stop sedation to see if there's an improvement in a neurological condition. And unfortunately, there was no further improvements. And 6 days later, there was a significant deterioration, requiring another scan of the brain, which showed that she'd had another large stroke. Following discussions with the family, it was decided that we had to look at maybe withdrawing care or not for resuscitation. The family felt very strongly that the patient and themselves would not wish her to stay alive with neurological disabilities and a very poor quality of life, which was the likely outcome from this last stroke that she'd had. So the family was spoken to, and the decision was made in their agreement that we would withdraw the treatment. And that means taking the patient off the breathing machine and taking the breathing tube out of their mouth. This we will do with the family's understanding of what is happening. We reassure the family about how we would manage the patient's pain, any sign of distress we would give the right level of medication for, and that we would promote a dignified and comfortable death. And overall in critical care, where we do see this, a lot of end of life scenarios, there comes a point that although our aim is to try and make people better and improve their recovery from illnesses and critical illnesses, generally do it really well. But in this case, it was really sad to hear that we got it very wrong, unfortunately, for this family. So what happened was the family were asked to leave the patient's room to go and get have a drink while we took them off the breathing machine. Now this is 10 o'clock at night, and I think the timing of this being done is something that was first learning point, whether we should be doing this at a better time of the day for families, but also, when there's perhaps a bit more senior support in the hospital. So the patient's family, of course, this is during COVID, there was no waiting rooms in our areas. So they went and were sitting in the main atrium, which was a very public space. And they found that quite distressing to be in such a public space dealing with such a personal and sad situation. To the point that one of the daughter's sister had ended up having a panic attack, which was very obviously difficult for them all to be dealing with that, as well as their mother dying. But it's they waited there for 4 hours. The breathing tube, to take a breathing tube out is a few minutes, and to settle a patient after that, not much longer. Somebody forgot to contact the family and get them back into view with their mother. The family, obviously not sure what to do, they waited and waited and waited. And when they had received no updates, they then returned to the unit. They were allowed back in, but again, to be sitting in a public area, feeling very upset and distressed, and then no updates for such a prolonged time is very, very difficult. And that should not have happened. So the other piece around that was the fact that the family saw the mother looking very distressed. They asked for her to have medication, and that wasn't forthcoming because they said that she'd had some earlier and she had to wait a certain length of time. Unfortunately, that's not the case. All end-of-life medications are given to get complete relief of symptoms. We cannot have our patients looking distressed. My review of the medication chart showed she'd been underdosed in terms of not having had sufficient, and then marrying that up with the fact that the relatives explained she looked very uncomfortable, very distressed, is obviously very disappointing to us. So a lot of we had a meeting with the family, with the daughter, and we talked through this, and it was really hard because we couldn't really give her much peace around that we had done everything we could have done. Unfortunately, but we hadn't done all that we could have done. But I think she found some solace in the fact that, and we were able to give her some reassurance about what we'd learned from all of this. She has gave me her permission to share the story and to use it for learning. I've presented it in terms of at our senior sisters meeting. I've presented also the patient experience and the mortality group. Triangulating this with the learning that the hospital had picked up, the structured judgment review that was done had stated that the end of life care was good, but clearly we hadn't got it as good as we would have hoped for the family's perspective. So from the mortality discussions, we're looking at how we can triangulate that, because the structured judgment reviews post-death are done in a much quicker time frame than we would have had received this patient feedback. But like I say, it's important that we get these feedbacks, but more importantly, it's about how we learn and what we put in place to try and make sure it doesn't reoccur.
Ruth, thank you for bringing that story to the board today. This is an opportunity if any of my board colleagues have any questions or comments that they'd like to make. I think importantly, Ruth, you have told us how you are now trying to use the learning from that, and perhaps the key issue is that it is possible to have a situation where the review finds that the quality of clinical care is good, but the way in which we consider the impact on patients, families and carers is perhaps not considered within the auspices of that. And that's obviously a very, in terms of patient experience at such a, family's experience at such a difficult time, that's obviously quite an important piece of learning that we need to be able to reflect back to people who, our staff who find themselves in a similar situation. Ruth.
Sorry, it's another Ruth to a Ruth, isn't it? Which makes it a bit more. I just wanted to say it's so refreshing to hear, like you say, when it's not a complaint, but not the response isn't defensive. And like you say, although you couldn't maybe offer her all the reassurances, actually, I think when people just hear honesty coming back, sometimes that's stronger than far stronger than a false assurance or a false apology. So I think it's very refreshing. The only thing I do question a little bit, and I think it relates more to critical care than elsewhere in the hospital, is that difficult situation of late at night being in the position of maybe needing to let someone go, and of course the ideal of in hours. But I guess the thing with critical care is a very, very precious bed. And is it correct that we delay that for a morning if there's someone else in the hospital that could really benefit from the very high specialised level of that care? And maybe we need to look around that more to, do we keep them in critical care then if that's the issue, or do we slightly, can we create something in critical care that isn't kind of one of those beds, so it's not super far away, but away enough that it allows the capacity for critical care to stay open like that? It's a difficult decision, but I think it's one that needs a lot more thought on.
Thank you for that, Ruth. I don't know if you want to respond to that, Ruth D.
So yes, beds are a premium, it's without a shadow of a doubt, and we are running at sort of 95% occupancy, which doesn't give us a great deal of wriggle room for patients that suddenly need a bed. And you know, people come through ED or deterioration on the ward, we need to get that patient into our critical care bed within an hour. That's the aim. We would do that. Unfortunately, that's hard to achieve, but the sooner we get a patient into critical care, the better it is, and it can improve outcomes, as well as making sure people are in a situation where, you know, if they're not in the right place, it can be more detrimental to not only them, but the staff around them who are out of their depth looking after sick patients. So that is the ideal. Yes, this did happen at a time where things were very challenging, and the demand on beds was huge. In my mind, and my personal view, it's wrong to have expedite somebody's care to create space for other, because even though they're at an end of life and we are not necessarily going to, you know, the patient is going to die, we've got to get that right. It's so important, and to rush that process. Yes, could the family have had another night with their mother? I mean, obviously you want them to be tired, but sometimes people need that time just to sit and hold their relatives' hands and say goodbye. To have to rush that piece, to get it wrong for them. You know, we cannot redo that bit. There's a lot of things that we cannot redo, and the impact this has had on the family is very profound, I'm afraid. It was very hard speaking to the daughter, and I have followed up with her since, just as like a check-in. And she's, you know, trying to come to terms with things that I've told her and so forth. So anyway, I think it's important the timing is during the daylight hours, as it were, would be important regardless of bed pressures.
I think Ruth's point wasn't it, not that it should be rushed, but whether or not it should be delayed, and if it in order to enable precisely what you've said, Ruth, and if that's the case and there is pressure on beds, whether or not it's possible to have an alternative place where that could happen. Matthew.
Yeah, I mean, thanks, Ruth, for bringing this. And I have to say, I think there's, you know, it's always lovely to hear compliments, but in some ways we kind of learn more when we don't quite get it right, and when we get things wrong, and when we recognise that and create the space for some of these stories. Partly because I think it encourages staff who work here to be more open to discussing these things. I think they need to see that we're prepared to listen and reflect. And I've met a number of families since I've been here who have experienced poor care. I should say that's in amongst a lot of really positive comments we do get, but the things they largely want to do is they want to understand what happened and why it happened, and really they're not necessarily so focused on blame or inquiries or punishing people. What they want to do is make sure it doesn't happen to other families, or doesn't happen to other people who are in that position. And I think one of the things in the pandemic, and that we've seen through the visiting restrictions, are really cruel, really, in their impact on people, because the thing you want to do when someone's at that stage in their life is be with them and spend every minute you can with them. And I think because of those protective measures that we took, I think it did put staff and families in this really difficult situation. And then the point about having to wait in the atrium while this was happening, I mean, all of us know what the atrium's like at Queen's. It's really the last environment you'd like to be in when you're in that kind of stage. And it encourages to think of the spaces that we create within the hospital. We've got the new residence room, relatives room, for example, at King George next to the intensive care unit, which I think is fantastic. And likewise here at Jubilee, we've really managed to provide some better facilities. But I think the learning is really important. The other thing's end of life. And Mamta and I and a couple of colleagues, Anne and others, were at one of the local hospices last week, actually, St Francis's. And it was interesting talking to them about how we try to have better conversations actually with families around end of life. Again, one of the features that's come through in a couple of conversations with families here is how suddenly they've arrived at an end of life stage. And I don't think that was necessarily the case with this patient, but I think there's been other situations where we've not necessarily had the right conversations during people's treatment pathways here. And it's a skill for clinicians to be able to have those conversations well. But it's an area I've been talking to Mamta and others, Anush Goblak and others, about how we focus really on doing those bits of the conversations better, and recognising that for all the sort of technical treatment we can put in place and the clinical treatment we can put in place in hospital, there is also that dimension of compassion in care that is very, very important, particularly towards the end of life. And sometimes staff are so busy and not necessarily supported to find the time and space to do these things well. But I want to say thanks to you and the team for bringing this story forward. I think it's good that we balance the feedback we get, because we learn more, I think, sometimes when we get things wrong than we do necessarily when we get things right.
Thank you, Matthew, and just to reinforce Matthew's thank you to you, Ruth, both for bringing the story to the board today, but also for the way in which you're ensuring that the learning is disseminated throughout the organisation. Thank you for that. Okay, let's move on then to the sort of formal start of the agenda. So we've got apologies for absence from Linda Story, the Company Secretary, and welcome to Rita Hall, who's the Deputy Company Secretary, who's looking after us today. Apologies from Jackie Westaway, Non-Exec Director, and apologies from Catherine Halford. And welcome to Sarah. Welcome to Sarah Dunton, who is Director of Nursing for King George Hospital, who's deputising for Catherine. And as she said, we have it's Anna Page, isn't it, who will be supporting you when we get on to the item on the nursing and midwifery 6-month staff review. Good. Okay, item number 4 is the Board of Directors declarations of interests, and that's been updated to remove a number of directors who've recently left the trust and to include MAMTA. So that's available for people to look at, which brings us to the minutes of the previous meetings, which I will just go through to make sure that everybody's happy that they are a correct record. So we're starting with the 10th of May. So put your hand up if there's anything that you want to correct as we go through. So we've got page 1, page 2, page 3, page 4, page 5, page 6, page 7, page 8, page 9, page 10, page 11, page 12, page 13, page 14, page 15, page 16. Okay, we'll take those as a correct record then, which brings us on to the 20th of June. Page 1, page 2, page 3, page 4. Okay, we'll take those as a correct record, which brings us on to the minutes of the board meeting, the extraordinary board meeting on the 29th of June. Page 1, page 2, page 3. Okay, good. We will take those as a correct record. We've got the action tracker. Sorry, we've got matters arising. First of all, we haven't had anything notified in advance. Does anybody have anything that they want to raise now? Okay, we've got the action tracker, which doesn't have anything that is current for this meeting, that enables us to keep an eye on what is coming up. Okay, let's come on to my report then. First of all, I'm pleased to be able to update the board on a couple of non-exec director changes, which are part of the work to support the collaboration with Barts Health. So Barts Health non-exec directors Cathy McLean and Professor Sir Mark Caulfield of QMUL will, in addition to their roles on the Barts Health Board, be joining the board here at BHRUT from the 1st of August 2022. And that's in addition to the recent appointment of Leslie Seary, our BHRUT non-exec director, to sit on the board of Barts Health. So that brings the number of joint non-exec directors across both boards to 3. And of course, Mark Caulfield is replacing specifically Anthony Warrens as the representative of QMUL. I'd also like to place on record in this public board meeting my thanks to Joan Sadler and to Anthony Warrens for their work as non-execs on this board and their service to the trust, and also to note that had she been here, this would have been Jackie Westaway's last meeting, and to thank her for her contribution to the trust, and particularly to the work most recently that she's done with the Quality and Assurance Committee as well. At the May board, I updated you on the appointment of Barts Health Deputy CEO Shane DeGaris as the Group Chief Executive and Single Accountable Officer across Barking, Havering and Redbridge and Barts Health. And you'll be aware, of course, that that appointment reflects the provider collaboration between the two trusts. But I'm also pleased to be able to provide a further update on that, and that is that in recognition of the shared leadership across the two organisations, we've also now formally appointed Matthew Traynor, our Chief Exec at BHRUT, to be the Group Deputy Chief Executive for Barts Health and BHRUT, and Matthew will also join the Barts Health Board as a voting member. And both Shane and Matthew take up their new roles from the 1st of August after Dame Olwyn Williams has formally stepped down from her role as the CEO of Barts Health at the end of this month. Alongside those appointments, we've also continued to make progress on the collaboration. You'll be aware from my last update that we were due to hold an informal meeting of this board and the Barts board in May. That went ahead. I think it was a very good session. We discussed the positive progress that we've made on the collaboration over the last year, in particular around having put the key enablers in place that will help us to go further in the coming months, and our plans for 2022-23 and the relationship between this collaboration and the acute provider collaborative, which is of course a broader collaboration under the auspices of the integrated care system, which also includes Homerton Healthcare NHS Trust, with the aim also to deliver improvements for the people of North East London in the provision of acute healthcare. We then also had, we decided that we would set up a collaboration committee to both track the progress with the collaboration and also to consider on behalf of this board and the Barts board future priorities for the collaboration, reporting back to the relevant boards. And we held the first of those meetings last Wednesday on the 6th of July, and the attendees there are the two vice chairs from the two boards, the joint non-exec directors that I've just outlined, and exec directors from each of the two trusts. And once again, we considered the progress that we'd made. We agreed that we wanted to undertake further work to scope out the priority programmes for the future, that we wanted to increase the pace of in this year on actions which particularly will have a measurable impact on patient care, our staff and our communities, because that's the test of the collaboration, the extent to which we can demonstrate the benefits that are coming there. And we also agreed that we would want a test of the collaboration to be the support that we could provide here at BHRUT to help to exit SOF 4 and therefore to support this trust in financial improvement and the very important work on urgent and emergency care that is underway. So whilst we've got some sort of concrete actions that we need to take there, we also celebrated the way that our staff are increasingly collaborating by default and pledged to support that as leaders across the two organisations, because there's a really very positive approach to finding the ways in which people can work together across the two organisations to improve all sorts of areas of our work. Just a few other things that I've amongst the things that I've been up to that I think are worthy of note. On the 10th of June, along with other non-exec directors from this board, we attended the North East London Integrated Care System Networking event for non-exec directors, where we were updated on the governance arrangements, and we also were able to contribute on a range of different workshop areas on how we can work together more effectively on people, on finance, across the ICS. And of course, since the 1st of July, the ICS has taken on its statutory form in terms of the legal establishment of the North East London Integrated Care Board, which is replacing the North East London Clinical Commissioning Group and is now responsible for planning and commissioning health services across North East London, as well as, and I think this is the most significant part of the new role, ensuring that all parts of the local health system work effectively together, and in particular that we make a reality of tackling health inequalities across the system. And we are very much looking forward to working with our partners in the system and with the newly appointed team in the ICS in doing that. I was able to welcome back in June Sukhvinder Kaur Stubbs, who's the chair in common of Hounslow and Richmond Community Healthcare NHS Trust and Kingston Hospital NHS Foundation Trust, who came to visit so that we could sort of compare notes of being chairs in common. But also I was able to show her the new Jubilee Intensive Therapy unit here at Queen's. And we had meetings with the lead chaplain, Phil Wright, and also with Chief Clinical Information Officer, Devesh Sinha. On the 15th of June, along with Anne Hepworth and other NHS leaders, I took part in a seminar on the topic of regional health inequalities organised by the Purpose Health Coalition. And the Purpose Health recently produced an impact report outlining some of the levelling up and social impact activities at Barts Health Trust, and they are now working with us at BHRUT to be able to produce a similar assessment so we can celebrate the very good stuff that we're doing on a whole range of areas where we have an impact beyond the walls of the hospitals, but also in terms of the support that we provide for our staff and in tackling inequalities, and that we're able to share that good practice and to learn from others. We've continued to brief local politicians about developments across our patch. On the 21st of June, we had our monthly meeting with local MPs to provide an update on trust issues. Getting out and about, on the 23rd of June, I went and visited the Royal Free NHS Foundation Trust in Hampstead, where I took a tour of their high-level isolation unit, which is used for the treatment of high consequence infectious diseases such as Ebola. It's one of only 2 centres in the country, so clearly very significant. But we also talked about the impact of monkeypox and other infectious diseases, and we met with the group chief executive Caroline Clark and with the chair Mark Lamb to talk about how that trust's group model is developing. And then last Friday we had a great visit to King George's by Ilford South MP Sam Tarry and Redbridge Council's leader Jazz Atwell, as well as the Health Scrutiny Committee Chair Beverly Brewer, the Vice Chair Councillor Sunny Bra and the Chief Executive Claire Simmons for a tour of the upgraded ITU at King George. They were very impressed with the unit, which is already having an important impact on our critically ill patients and on the well-being of our staff. And also we were able to talk to them about the way in which in critical care, for example, we're working not just across our trust, but also increasingly effectively across the whole of North East London, and particularly our collaboration partners at Barts Health. So that is my update. Are there any questions or comments that anybody has on that? Okay, thank you. Let's move on to the Chief Executive's report then, Matthew.
Hello, the Chair. Thank you very much. Right, I'll switch my fan off so you can hear me. But it's punishingly warm.
We're all your fans, Matthew.
Thank you, Jackie. So, right, so a couple of things from us. You'll have read my report, I think, this month, but I just wanted to pull out a couple of things. One is there's a number of exciting developments, I think, in terms of things that are being built across our 3 boroughs to create more capacity to deliver care in the right place. You'll read in there in the update about, we know we've got the work going on at Barking Community Hospital. We're also looking at St George Community Hospital, and it took me a few months to stop getting St George and King George's confused. But there's an opportunity for us to move our large renal outpatients unit, which sits right in the middle of our emergency care area, off-site in the next couple of years, which would be fantastic for our work around our front door. And there's also the old ice rink opposite the front of Queen's Hospital as well. And we've been talking to some of our local partners about how we can perhaps better use that space to deal with the increasing number of people who are coming to the Queen site to access both urgent treatment and care, but also sort of same-day primary care as well. And we know that our colleagues in Pelker are seeing increasing numbers of people who are coming in there as their way of accessing primary care. And if that's what people are choosing to do, we need to think about how we provide the right resources for them. So there's a couple of pieces of work there in the pipeline that over the next couple of years will see us expanding the footprint of where we do that and looking at where we can offer care closer to where people live, and not necessarily meaning they have to come into the Queen's site whenever they want services from us. And I think that's really positive. Of course, that does take us into what we're doing around the front door and around the urgent treatment centre. And there's some information in the update about the work that we're doing with the partnership of East London Cooperatives, who are the GPs that run the walk-in centre here. So if you do come into Queen's and you walk in for emergency care, who you're seen by first and foremost is our GP colleagues working in the urgent treatment centre there before you might get referred through to the emergency department. We've made some changes to the way that front door works to reduce what are sometimes at times extremely long queues there in the atrium. And we're also working more closely so that some of our staff are more actively taking part in that streaming at the front door, triaging to make sure we get the sickest patients through to the emergency department. But as it does say in my update, if you're coming here because you've got something that you would have gone to the GP for, you may still be facing a really long wait to be seen, because we are always prioritising the sickest patient and pulling them through. And I know that as the teams work together to manage that, we're trying to make sure that people have that information and recognise actually that there's other places across the 3 boroughs where you can go for that kind of same day access to care, in addition to our GP colleagues who I think are working hard around the clock to make sure that they see and treat as many people as possible. There's some information there about how we're managing flow in ED, a couple of the initiatives we've been doing. The ambulance receiving centre you've heard me talk about before, we got a nice piece in the Observer about that earlier this month, and what you can see in there is that although the ambulance numbers coming to Queen's have been increasing, the ambulance handover delays have been decreasing at the same time, and that's through us running that really effective joint model with London Ambulance Services to try to make sure that people are getting care in a more dignified environment. And they're being seen now by a joint triage process of London Ambulance and Queen's ED staff. And it's a model that I think is really interesting. We're now seeing paramedics taking bloods, helping get people cannulated as well down there in the ARC. So we're increasing the scope of what the paramedics can do alongside our teams. And the patient feedback we're getting from that is really, really very impressive, actually. And that's allowing us to do that front door piece around ambulance handovers better. Also in there's information about the work we're doing across the whole hospital, because where you see problems in the emergency department, it's really a factor of a couple of things. One is the volume of folk coming through the front door. Another is what happens in the department, but it's also really important what happens in the hospital when we're sending people home and creating capacity from beds. And then over the next couple of months, you'll hear more from us around that, including a pretty large rearrangement of the emergency department we're going to do over the summer to try to create capacity here before we go into the winter. And once we've completed some of the work at Queen's, we'll be having a really good look at King George as well, who are also struggling a lot with flow at the minute. One real noticeable pressure has been the increase in waits for people in mental health crisis or people with severe mental illness who are coming into the emergency department. So we've seen, I mean, it's terrible that we have to look at this metric, but we've been tracking the number of people who spend more than 36 hours in the emergency department from January through to May, June. And while we've seen the overall number decreasing steadily and consistently over that period, we've seen a real sharp increase, particularly in the last 2 to 3 months, of people in mental health crisis spending a very long time in the department. We now know that more than half of the people who come in with mental health as a primary reason for attending, more than half of them will be in the department for more than 12 hours. And around 10% of them are spending 36 hours or more in the department. We recently had a woman with learning disabilities who is in the emergency department at King George for more than 300 hours. And we also had a child who we admitted to the paediatric ward actually at Queen's in the end, and she was with us for 26 days before she could be transferred to an appropriate care unit. And in that time, we had to close 3 other PEDS beds so we could care for that person in the right environment. And I think when we see these kinds of pressures coming through, it shows that the system as a whole is working very, very hard to try to cope with this. And it's worth pointing out that in those cases, actually, those 2 people weren't waiting for mental health beds. They were waiting for other kinds of placements, some outside London as well. But what we're seeing coming through the front door, particularly at King George, actually, is a real surge in demand for people who do have mental health problems, and we were working closely with our partners at Nelft and others to try to do what we can to manage that. But that is a growing problem for us at the minute, and it's a growing problem that we're trying to figure out a different way of doing this going into the winter, because it has a really significant effect on the department, and ultimately it's the wrong kind of environment for someone who is in mental health crisis to be cared on for such a prolonged period of time. And elsewhere in the report, there's some really good news about some of the work we're doing elsewhere, particularly in terms of planned care and diagnostics. Our endoscopy department had a visit from the National JAG accreditation team, and they said that they thought it was one of the best units they'd seen in the country. They said it was on a par with some of the very best tertiary services they'd seen elsewhere, and said that we should be aspiring to that level. And they reflected that when they came here 3 years ago, I think there'd just been a fire in the decontamination unit, and it was literally a kind of smoking ruin. And from that, as a result of some of the very strong clinical leadership there, and colleagues like Sas Banerjee, colleagues like Esther and others in nursing, and Petra, they've done a brilliant job in rebuilding the department to the stage where we've got one of the shortest waiting lists, I think, in London, and people there are getting absolutely first-class care. And it's brilliant to see that recognition of the tremendous work that Sas and the team in endoscopy have done. And we've also got some superb cancer results as well around the first treatment as well, some really strong waiting list work there, and people in North East London are receiving some of the very best access to that sort of first definitive assessment that we're seeing in the country. And also on the 104-week waits as well. Recently we updated the board on the situation that had arisen because we'd identified a group of people who'd fallen off the referral lists from primary care, and so we had to see if we could get them treated rapidly. I think when I spoke to you last, we had 219 104-week waiters there, and I'm pleased to say that at the end of June that had been reduced to 3 people, and in each of those 3 cases there was a good patient choice reason why those people were opting for not being treated at this point in time, and they will of course be treated in due course. We do though have a growing waiting list. More people are coming on the front end than are going off the back, so we've got quite a bit of work to do to keep pace with that increased demand. You know, the diagnostic stuff's working quickly, but that means that the waiting list grows, and there's a significant number of people out there who we're going to have a look at, triage their cases and decide what they need to receive, whether it's surgical treatment or other forms of care. And a theme I think the board will pick up over the rest of this year is that work we're doing to really start to shrink that overall waiting list, particularly tackle now our 52-week waiters and make sure people are getting the care they need promptly. So they were the key things I wanted to pull out from the report. Other than to mention COVID, can't help but notice it's very much out there again at the minute. Cases are ticking up a bit amongst the staff and the patients, although it feels different this time. And I think you know, we're waiting for news on booster vaccinations, hopefully in the autumn. For staff, I know as well some vulnerable patients are receiving them at the minute as well, so we'll be keeping a weather eye on that because it will affect the way that we use our capacity and plan for the winter. So they're the key points I wanted to pull out, and happy to take any questions.
Thank you, Matthew. And your point about the way in which patients who attend with mental health issues and learning disabilities are having to wait really wholly unacceptable lengths of time is a sort of key challenge for the integrated care system, isn't it, being able to work? effectively together, both in terms of NHS providers and, as you say, other provision as well that is necessary for people to be able to get to the right place at the right time. Are there any other questions for Matthew? Okay, thank you. Which takes us to the quality and safety part of the agenda and the Quality Assurance Committee report. First of all, Ruth, you're going to present the key issues escalated from the committee from the meetings held in May and June. Thank you.
Thank you, Chair. So I'll take the report as read, if that's all right, Chair, but just to pull out a few things that we wanted to take forward to the board. So there's obviously a lot of change in the maternity unit, but a lot of positive change responding to the Ockenden report. The thing probably we wanted to focus on more, we did a deep dive into radiology concerns in there, and a lot of positive feedback from that, a lot of changes, so that you'll see to try and mitigate those risks. 4 new radiologists have been employed working at external companies to do some more reporting, to kind of bring forward funding for reporting. So essentially reporting costs, it doesn't really matter when they do it, but really pulling that forward and trying to get this backlog down as much as possible. But there's also a lot of background work on increasing the IT part of radiology to make it more efficient and valuable in the trust. And then the only other thing we wanted, a lot of it is going to be covered in some others, but prevention of future death, we had one from the coroner, but that's all being focused on and no concerns. And the monkeypox update, that we have a new steering group with key stakeholders to make sure that we're all aligned and respond appropriately.
Great, thank you. There's some really important work in that committee, as we can see, on some of the sort of key areas relating to quality. I just had a couple of questions. I wasn't quite sure why we've got this unavailability of the maternity services data set, which seemed to be quite a significant risk. And then the other thing I was just going to say, in terms of the things that the committee is thinking of looking at in the future, one of them was the update on the digital strategy. I think that's quite important. That comes to board as well, or instead, depending on what the best way of doing that is. Sue, are you answering my question?
I'm
No,
not answering your question.
No, you should. I wasn't expecting you to. But you were looking very enthusiastic on my screen.
I do have questions, though you've stolen my thunder on one. So do you want me to do that now? I've got them on.
You fire away with your questions, and somebody can decide who wants to respond on what we've said so far. Go on.
So you made reference to the maternity data, which I note in the report is because the system is unsupported, which means the software has gone out of support, which suggests a delay. And there is also a reference to the RIS-PAC system also being out of date. And I guess it just joins some dots for me in terms of how on top we are of the age of our IT systems, what processes we have for monitoring that to make sure that situations like this don't arise again. So it's just really expanding on that point, Jackie. Thank you.
Okay. Thank you. Linda?
Thank you, Chair. I'd just like to make a few comments about the patient experience aspect of maternity. We're currently doing the WAF in there, you know, the ward accreditation framework, and patient partners are actually contributing quite heavily to that. I've done a couple myself. I've got one later this week. And I have to say that, and also we're doing a lot of work on collecting FFT, you know, friends and family test information. We've started to do that. Catherine has particularly asked us to do that. And I've done some of those myself. And I think what has surprised me is, whilst there are some very, you know, positive things, you know, people say it's been wonderful, etc., etc. And there was a guy on Sunday who said that his wife had her first baby in the Portland, and this was just as good. So, you know, that was a really nice compliment. But on the other hand, I have to say that there's been quite a lot of negativity about the service that's been produced, that they've received. Communication has not been good between staff and the mother and their families. There have been delays in responding to call buttons and stuff like that. So it's actually, I was unpleasantly surprised, if I can use that term, about how many negativity comments there were. Now, clearly we're in the early stages of collecting that data, so it may change over time. But it was a surprise to me, whereas, you know, people, it's a wonderful experience to have a baby, and it's usually a wonderful, you know, babies are lovely and cooing and that over the babies, which has been quite pleasant for me. It's a long time since I had one. But there was quite a lot of negativity there, which, as I say, I think is a surprise. So obviously, as that the WAF continues, and I think we're getting close to the end of it, and the FFT stuff is done, then I think the more balanced picture may come forward. Thank you.
Thank you, Linda. Mamta?
Sarah's just going to.
So I was going to touch on the previous question that you asked, Jackie, and I was just going to touch on it, and I was going to talk about it very briefly in the following paper. But my understanding about this risk that we're adding to risk register of maternity not achieving action 2 in the maternity CNST is due to not being able to gather the data and the different IT systems not linking up. So what they're doing at the moment, I understand, is they're looking at whether they can collect it manually until they can actually get the system sorted. But I don't really understand the IT behind it. But that's really kind of like a basic understanding of what's going on there.
I think, yeah, I think it's a standalone system, Jackie, and the standalone system doesn't communicate with System C very well. And so the point about bringing our digital strategy, and I know Nick has been having multiple conversations back to either QAC or the Trust Board, is a point well made, because the age of multiple systems is different, and we need to be cited on it as to how it communicates, what's the impact, and what are we doing about it till we get the longer term EPR strategy.
Yeah, good. I mean, it's quite a sort of key risk and issue for us. So I think probably board is the place where we should consider it. Ruth.
So I was going to say something very similar to Mamta. So I think we're in that real difficult point of the limbo between systems and trying to just negate as many of those risks as we possibly can. I don't think we can negate all risks, but we'll have to assess those as we go along. So we'll bring that back to board. Also, just to respond to Linda, I think that we're not surprised maybe that we've had some I'm not surprised we've had some negative feedback come from maternity. I think what we've found very difficult is to get fruitful feedback from maternity before. So it was very difficult to work out how we could action anything from there. We've just had a sparsity of it. So I think your work is really valuable because it will allow some learning and some feedback and some improvements to be made. So hopefully once that's wrapped up, that can come back also to QAC and see what the learning points have been to move forward with actions.
Matthew. Oh, no.
Yeah, I stuck it in the chat, Jackie. I mean, there was a brief mention in my CEO report of some of the challenge we're dealing with in terms of our systems. Yeah. Because we've got lots of small independent systems operating in silos that don't speak to each other, all of various vintage and not particularly effective in some cases. And Peter Hunt put together a superb short film that gives you, it's a bit, if any fans of Indiana Jones will recognise the warehouse from the end of that as basically the medical records section of Queen's Hospital. But we are pretty much the last acute hospital in London that still runs pretty much as a hospital run 20 or 30 years ago. We're increasingly out of step with the expectations of staff coming here and trainees coming here who have to learn ways of working that have largely been consigned to the past in most parts of the NHS, certainly in London. And I think it's very helpful the NHSE and the North East London ICS are committed to support us with the development of a proper electronic patient record. But that film really brings it home to you, and thank you to Peter for a really first-class piece of work on that. Thank you.
It's very good, Peter. You should consider doing it for a job, you know. Mamta.
Jackie, and also to reassure you, all of these issues that we think are in limbo, Nick and I have been working through it in terms of what is the mitigation, what's the time frame that we need to put into a mitigation, and that comes in possibly with additional staffing to support us with that. So we've looked at particularly EPMA. We had this conversation about on Friday. It's going to need additional staffing to mitigate the risk, because at the moment, as Ruth suggested, we're in limbo and we need to think about how we mitigate against this risk and how long it's going to take.
Okay, good. Thank you for that assurance, Mamta. Right, let's move on to the Integrated Quality and Safety report then. And I think, Sarah, you're going to give us the key points.
Yeah, hello, thank you. I'll take it the paper's read, but the key points really I was going to discuss are that we have had one never event. I'll go in a little bit of detail of these headlines. We've had a Regulation 28 served. We've had 100% response rate to our complaints, which is something that we're all very proud of. Mandatory training is above 90% now, and I was going to touch on the risk in maternity, but I won't mention it now because I think we've done that. So we continue to report a high number of incidents. We have 87 per 1,000 bed days, which remains high since November. But within that, our clinical incidents continue to decrease. We went down to 944 in May, which was a reduction of 500. So I think that's a really good move. That was attributed to the redirection in the 60-minute offload breaches reduction, and that went from 631 in April down to 218 in May. The 12-hour trolley breaches are decreasing, and a report has been sent to CCG detailing the outcome of the review that we've had of that. We had 8 serious incidents, and they're summarised in the report, as are the learning outcomes and actions. Unfortunately, we had one never event in May, which a number of people that are on attending this meeting are fully aware of, and it was when a patient fell out of a window at King George. It was very distressing for the staff. I'm pleased to say the patient is now up and mobilising, and was last heard to be mobilising with a particular frame. So she's survived, and it looks like she's going to be able to walk again. As a result of that, all windows on the first floor of King George were refitted with the locks, which means they can only open, I think it's about 10 to 15 centimetres. You can imagine the impact that's having on everybody at the moment with the heat. We reviewed all the windows at Queen's as well, and we sent out an internal alert to staff and reviewed any CAS alerts that we had. We've had a reduction in the number of falls, and we had no falls with above moderate harm in April. We've had updates, or we've updated our guidance in line with national and London IPC COVID guidelines. The swabbing has changed, and the way that we segregate our patients has changed as well, and that's obviously brought its own issues in the recent few days. The Regulation at 28 report was issued in May, and that's due for submission in July, and this related to a patient who had surgery and then developed respiratory problems and sadly died. And the key points from that are the primary documentation needs to be better, and end-of-life care. We've had new patient partners recruited in May, and I'm delighted to say we've got one in King George ED, and they'll be very welcome. And we have one for patients with learning disabilities, which again will be very welcome. And it's really lovely to see so many of our volunteers back on site and helping patients and staff and visitors move around the trust. Our mandatory training overall is 92%, which we're really pleased with. And then I was going to touch on the risk of maternity, but we've already talked about that. So that's it in a nutshell, really.
Okay, thank you. So any questions or comments? I just had one sort of presentational comment, really, that I think I made last time as well. The first line of the cover note talks about the high number of incidents with 87 reported per 1,000 bed days in May. The trust position remains above the trust level target. Just to clarify, as it does make clear further down in the report, that is a good thing to have a high level of incidence. I'm not sure it always comes over clearly when we say that. Clearly, it's then important to be able to determine that they are harm or very low harm incidents. But the higher the level of reporting of incidents, the better it is in terms of being a safety conscious organisation. Any other comments or questions? Sue?
Thank you, Jackie. Hi, Sarah. I note from the report, looking at all the charts, there's a bit of a consistent message about capacity in dealing with incidents and the pace of dealing with incidents, both within the team that investigates, but also within the divisions in responding and implementing the actions. I also note you said that you're going to do more training for people to be investigators. That's really positive. But I just wanted some clarity about whether we're targeting enough people to be in a good steady state, and therefore what we're going to do about this backlog, both in terms of investigations not yet completed and actions not yet implemented. Thank you.
So can I answer that, Matthew, before you come in? Yeah. So I've been looking at this entire and it relates to my next report as well. So I've had a conversation with the coroners to understand from them their perspective of what a safe organisation and where we are in BHRUT. So they have assured me we're not outliers. Looking at the SI process within divisions, I've been working with Lorraine, and we're waiting for Catherine to come back from leave to look at how do we reframe what good incident reporting is, what good M&Ms look like, what is a good SI investigation, and how are we transparent in sharing that learning between divisions. At the moment, it's held quite divisionally rather than as an organisation as a whole. So we've helpfully pulled together learning from SIs as all the SIs for the month. What have we learned? What was the incident? What have we done? And what have we learned from it, so that we can share it across with all of the members of staff within the organisation. In looking at the investigation reports, I think the quality of the RCA is probably not been great. And that's partly because I think the nurses have done an amazing job, but the doctors are not at the table as we should expect. So I'm meeting with all of the divisional governance leads, and we have a workshop planned for the first week of August to say, rather than be critical, to say this isn't quite what we need to happen, how are we going to make this better, and how are the doctors going to play a part with the nurses around the SI investigation. So I think there's a big piece of work which we are doing around governance and around the backlogs and what kind of timeframes and what support they need. And I think the central team, which is Lorraine and et al., have done an amazing job. And there is a capacity issue, but we need to address how is it distributed between the division and between the corporate function before we look at investing, if at all, anymore. I think we need some clarity around that.
Matthew?
Yeah, and I was just going to add as well, of course, I mean, Sarah mentioned that we'd had a never event, and these are things, you know, as per their name, should never happen. And it's important, I think, that people are aware that we have had this. It was in a circumstance where, and just to reassure people in terms of the safety of the site, this was not a sort of casual incident where someone was near a window and there was an incident involving it. You know, it was a relatively determined effort to overcome restrictive measures that were in place to prevent the windows from opening. But with that in mind, and also given my earlier comment about the number of people we are seeing in increased mental ill health and with increased distress, we are having a really good look at both sites to make sure that, as far as possible, consistent with, you know, a reasonable environment for the care of all patients, that the windows and things around that are in good shape as well. So, you know, it's important though that when trusts do have never events, that they talk about them and that they recognise the implications of them for our services more broadly. But I just wanted to reassure the board that that's something that we're pursuing an audit on both sites with considerable pace. Thank
you, Matthew. Okay, let's move on to the learning from deaths Q4 report. Mamta, I think you're presenting this.
Yes, thank you, Chair. So I think I would take the report as read. What we've done is we've looked at, as expected, we've looked at our nosocomial infections leading to death. We've done the learning disabilities mortality review, and we've taken a good look at how do we do M&Ms within the team with the implementation of the medical examiners, which I'm sure you're aware of that is supporting the learning from all of the deaths? How does that link in with divisional M&Ms? And where is that feedback held, particularly because medical examiners are talking to patients following the bereavement, or patients, their relatives following the bereavement? How is that learning then translated back to the M&M conversations that are happening within divisions? And I think Peter Tanner and Ahmed Solomon are doing an amazing job in trying to triangulate that and share that between the organization, and this is particularly for the two sites. So I think in summary, we've looked at all of our hospital-acquired COVID deaths, and while we've had, we're not an outlier for the number of nosocomial COVID-related deaths. Whatever we have is probably not, well, not as good as it should have been, but it is, we are learning from that, and we are looking at what steps we need to put into place. And this includes the MRSA and the C. diff infections as well, which are related, not just related to COVID. And within the non-COVID mortality, we are within the SHIMI range for nationally.
Thank you, Mamta. Any questions or comments from anybody? You mentioned the medical examiners. Now that's a relatively recent initiative, medical examiners, isn't it? How many do we have, and do we have enough? And is it something that we think we should? I haven't finished yet, Mamta. Number one. Number two, can you just explain what an SJR is and how it's carried out? Thank you.
So I think in relation to the medical examiners, Jackie, I've met with the team just recently. For the way the medical examiners, it used to previously only look at hospital-related deaths. There's an ambition that this is extended to the community deaths as well. So we're working with our primary care colleagues and looking at what infrastructure we need to look at all deaths within the boroughs that the hospital serves. So we have enough for the hospital, for the deaths in the hospital. And I think we've got fully recruited maybe a couple of weeks ago. And how this conversation between the medical examiners relates to the M&M learnings, because I think the conversations that we do with the relatives is by the medical examiners, but the M&M happens as purely a clinical conversation. And as we heard from the patient's story, how does that triangulate between the medical examiner to the M&M so that doctors are aware of the experience patients have during the bereavement? And then the second question was around the SGR. So Jackie, I'm not sure about that, so I will come back to it. I don't know that for here.
It wasn't I know it's spelt out in full later on down in the report, but this is one, a dislike of acronyms, and two, it's not something that I'd come across previously. So I just thought it would be helpful to spell out to people what it was. But if we can do that, that would be great. Just sort of, I don't expect a response to this, but just on the medical examiners, I wonder, and I don't know what the answer is. I wonder, but I hope and believe that medical examiners can sometimes make it quicker to ensure that there is clarity for families about cause of death, and therefore that we can release bodies in order for people to carry out funerals. And I had a very good and interesting visit a couple of months ago to the Brick Lane Mosque, and particularly to their funeral services, where they actually felt that they have a very good service, both from us at BHRUT and at Barts Health. But obviously, sometimes things don't happen quickly enough in order for there to be burial in an appropriate period of time, both for them and for people from the Jewish community as well. Are there any other questions or comments to Mamta? Okay, thank you for that. Nursing and midwifery 6-month staff review, Sarah. If you're talking, you're on mute.
My technical officer is not up to speed. I was just saying it's a very long report, so I'm going to try to summarise it, but there's quite a lot of information that I think we need to just talk about. The paper's written to demonstrate the 6-monthly safe staffing review that's carried out, and we use a triangulated approach with evidence-based and clinical and professional judgment to come up with the establishments that we believe are required, and it's really presented to the trust board so that you're assured that we are regularly reviewing and increasing and decreasing establishments as we believe to be appropriate, not just always asking for extra staff. So 42 units, which are wards, critical care, other departments, were reviewed in collaboration with our workforce hub and the senior nurses in the trust. The results speak for themselves, but we had 13 areas that we thought were just right. 14 had previously required more staff, and that had been secured. 10 we required an increase in establishment, and there were 4 where we believed that there should be a reduction in the establishment. 2 of those areas we've already removed the staff from, and the other 2 we are redeploying until things settle down post-COVID and we know that we've got the right cohort of staff for the right cohort of patients. The SDEC will require a business plan if it's to continue as a permanent service, and if we don't fund the SDEC, if we don't fund the SDEC, we will only need an uplift of 3.15 whole-time equivalents across all 14 of the departments. But if we do fund the SDEC, it'll be a total of 17.5 whole-time equivalents. Some of the areas where the establishment review in September 21 showed an uplift was required had a bit of a delay in getting the funding and getting the rosters templates up to speed, but that's now all in place. On page 4, we've got an overview, and it demonstrates the nursing midwifery staffing matrix comparing March 20 to 22, and it shows that the establishments are adjusted in line with the service change and the reviews. The required increase in funded staff was partly due to an increase in the acuity, which was wrought by changes brought on by COVID, and also changes in ward design and increases in capacity. So we had an additional 62 beds, and we had an additional 240 nurses to support that. Page 6, the table shows the plan versus actual hours and the fill rates, which has gone up to 98% in March this year, and previously that was 88% outside of the COVID surge. Our vacancy numbers increased in September, and this was due to the increase in the establishment, and we think that this is going to probably show back in April, May data again with a further increase, but people not yet in post. We're working to grow our own staff, and we're also recruiting from abroad. We're doing some work looking at other groups such as our healthcare assistants, and our intern team are doing some work with them. And then just I think to prove what we have done within a couple of divisions, geriatric and surgery reviews, both divisions show that they required an increase in some areas and a decrease in others, and that's what I was referring to earlier. So geriatrics had a gap of 4 whole-time equivalents and surgery 3.6 when we looked at the increases and the decreases. Maternity has a 3-yearly review. That was last done in December 2020, and that showed that the number of staff that we had in our established funded posts was appropriate in line with the ratios of midwives to births. Our mitigations for shortfalls ongoing are when staffing is considered to be low or dangerous. There is a red flag that is raised, and the matrons, stroke divisional nurses, and whoever else is required look at mitigating that by moving staff around and implementing any other actions that they think are appropriate. And then just touching on mental health, which Matthew mentioned earlier, the mental health registered nurse fill rate is really challenging across most acute trusts. And what we've done here is we've piloted with support from the workforce hub, and trust temps looking at using mental health experienced healthcare assistants to support giving one-to-one care to patients who we couldn't get registered mental nurses to work with. And where that's happened, we've noticed that it has really supported the care, the safety of that patient, and it's proved to be financially quite helpful as well, rather than getting other qualified nurses. We've got these healthcare support workers who've got experience and want to work with the mental health patients. And then the actions are on the final page. I haven't got to hand. So the board is asked to note the information in the report's finding, which included the areas where we're decreasing staff. To note the analysis is completed using evidence-based tools. Note the divisions will seek to uplift and decrease through the necessary authorisation and approval process, and support the continued review of staffing levels through the triangulated and evidence-based tools. That's kind of it in a nutshell, though. It's a big shell.
Okay, thank you, Sarah. Marta.
Thank you so much for the report. At the first time through, I found this a lot of information to digest, so I'm not entirely sure I've totally got it right. But the one thing that struck me is just wanting to understand the link between the outcome of this review and, in some cases, there is a recommendation to increase staff, in other cases to decrease staff. But I'm just wondering overall, where did we land in terms of staff increases, and what impact that's likely to have on our financial management, which is to try and reduce the deficit that we have. So it's a kind of combination between your work and the knock-on effect through to finance that I'm trying to understand a bit better.
I'm sorry, I didn't get the first part of your question. There were two parts. One was about the financial deficit, but I didn't hear the first question.
But what I was trying to understand is, overall, as a result of the review you carried out, what does it mean in terms of our staff complement? Is it an outcome that says we have to increase the number of posts? Because there's an issue about the number of posts we have, and then there's the issue about filling those posts.
Yeah.
So what I'm trying to understand is, as a result of the 6-month review, is the overall conclusion that we need to increase the number of posts? And then if that is the overall conclusion, the finance aspect of it is, have we evaluated the cost of that increase and where that money is going to come from?
So I touched on that earlier. If we keep our SDEC, we need an uplift of 17.5 nurses across the 42. The balance is 42 areas that we have looked at. If we don't keep the SDEC, we only need 3.5 nurses. I
think the thing is, I don't understand what the SDEC is, which is probably why I missed what you were saying. Could you just explain that to me, please?
Sorry.
So Martha.
Ban on acronyms, ban on acronyms.
Sorry.
Sorry, let me just, so what happens when patients, there are different pathways for patients to receive emergency care. There's those who need emergency that need to come to ED for restart, stroke, severe illness. There are those that are seen by the GP and can come on the same day to meet their consultant of their specialty that they need to see and be managed through that without coming in through ED. So SDEC stands for same day emergency care. And what we are trying to do is to support our GP and the primary care services within our patch by having more of SDEC, because that would be the right thing for the patients. So if they go to the GP and they need to see their hematologist, rather than turning up an ED, they get referred to the hematology service in SDEC so that they can come in there directly and be managed through that pathway. Now, more and more in the NHS, we're trying to support SDEC models because it works better for patients, it decongests ED, but there's a whole issue around getting the right staff to be able to deliver that. And Caroline is on the call. We had a conversation with our ED consultants this morning about what can we do to support SDEC rather than bring patients into ED, what kind of a model we need within the wards, whether that's medical or surgical, where they come in and see the consultant physician or the consultant surgeon rather than coming to ED and waiting for 6 to 8 hours for a registrar to see them. So that's the difference between the SDEC. And so if we don't do SDEC, we need 3 nurses. But if we need SDEC, then we will need 17 nurses. And my view would be that we need to support SDEC because our primary care is unable to deal with the issues for capacity reasons, or rightly or wrongly. They shouldn't be coming to ED, and that will help our ED performance as well.
Thank you. I think I've got it. Thank you.
Ruth.
So the 2 things that really struck me was one, just our general increase of employees. And when you look at it over the years, it's quite fantastic in the recruitment process. Yeah, I'm in awe. Trying to keep my team of 40 together, I can't imagine quite that many thousands of people. The other thing that it didn't concern me, but I just wanted to know if you had any idea of, we're obviously down in HCAs in total, and there's also quite a high turnover of HCAs, and I wonder if there was any kind of reason for that, if we looked into that in any way.
Yeah, it does touch on that in the report, where a lot of the HCAs are trained up to become to do other roles within the trust. So a number of them will go on to do their registered nurse training, and others will go on to do more technical roles within the trust. So we don't see. My impression is that we're not losing the HCAs, but we are managing to develop and upskill them. So they are no longer HCAs; they are doing other roles.
Sorry, I missed that. Thank you.
That's okay.
Sue.
Thank you. Just a couple of points. I'm not sure they're questions, maybe something for the future. One, to remind board colleagues that we have asked our internal auditors to do a review of the Safer Nursing tool, because it's clearly something we are massively relying on to give us assurance about levels of nursing. So it will be really helpful to us, I think, to get that independent assurance about how we're using that tool. And then the second thing, which is slightly more of a question, I would find it quite useful when we have these reports presented, when you're talking about vacancies, if we have an indication of agency level as well, because I think it is quite likely that people interpret vacancies as gaps, and clearly the level of vacancies isn't actually the same as the level of gap, because I think we are doing fantastically well at getting agency and bank, more importantly, into the system. So if there's some way of weaving that into the analysis when this comes in 6 months' time, I would find that quite useful. Thank you.
Good, thank you. Marty, is this another thing, or is this an old hand?
Sorry, I will do the housekeeping. I beg your pardon.
No worries. Good. Okay, thank you for that, and responding to questions and some proposals for sort of further clarification next time round. Which brings us on to the People and Culture part of the agenda, and the People and Culture Committee report, which Leslie is going to present, but she is, as she said in the chat, currently doing mystery customer duty at the Whips Cross. So, but she tells me that she's content to pop out in order to do this. So Leslie, thank you for this, but we will quite understand if you have to run away.
It's right, it's a welcome relief after 4 hours sitting in it at Whips and having to resist the temptation to redo their processes for them. But I'm sitting here being very quiet and well behaved. So the People and Culture Committee has been having a focus on the people strategy and looking at deep diving 2 areas each meeting. So we looked at leadership and talent, and in particular talked about the important role that leaders have in setting the culture, improving the culture, and in particular tackling, sorry, it's terribly noisy here, tackling bullying, harassment, misogyny and racism, and the work that's happening with the King's Funds on early intervention to ensure a safe environment for staff to tackle inappropriate behaviour. We also looked at well-being and some of the, I have to say, a really good work that's being done to help staff tackling the cost of living crisis. And I think the group that's been meeting on that has been doing some great work. We talked a bit about Careers Week, which I was really pleased to be able to go to and do the closing remarks at the end and unveil the artwork, which included dipping my hand in paint and adding my handprint to everybody else's. I think one of the really nice things about that, talking to the staff, was that the artwork is the handprints of all sorts of people that are involved in working at Queen's and King George's, and they'd asked a couple of volunteers to do their handprints as well, and their response was, nobody's ever asked us to do anything like this before. We're not really staff. And there was a good conversation actually about the importance of volunteers, and without them the hospital wouldn't run. So I'm really pleased we've got some handprints from volunteers as part of that. Most of the focus this year was on internal staff learning, but sort of in line with our role as an anchor institution, we did have a really good careers festival, careers fair, where local people, schools, colleges all attended. We talked about the People with Lived Experience Charter, which is around opportunities for young people and care leavers in volunteering, training and employment. We were the only acute trust involved in that, and we got a silver award and are now going forward to the second stage of the programme. There's a list of the other issues that we talked about, and in terms of the EDI update, the gender pay gap is separately on the board agenda as the next report. And apologies for the building work and whatever it is that seems to be going on here behind me.
Thank you for that, Leslie. Not quite enough building work going on at Whipps Cross at the moment, or yet.
I know, more would be better.
And I have no doubt that Ralph and the team will be very pleased to hear your views on how their processes could be improved. Matthew.
Yeah, and Leslie mentioned the cost of living group, and I just echo what she said about the good work that's going into that. We've got a significant number of staff now who are really being affected by everything from fuel prices to the cost of food. We've been talking to staff about things like school uniforms for going into the new school year and so on, and all these pressures that people are feeling on their budgets that are making it harder and harder for some of our staff, particularly those at the lower paid end, to get through the week and get through the month. And there's been some great ideas going into that. We're trying to move away from the give everyone a lump sum of a couple of £100 that's gone by the end of the month, because I think that's relatively short term, and also there's tax implications from that kind of thing that mean it costs the trust a lot of money, and we're in financial special measures, so we're not really in a position to do that. So we're more looking at sustainable things that can help people over a period of time. Stacey and the team have put together some really good information packs as well to help people with things like budgeting and managing their finances, and also to point people towards a number of things that NHS staff and public sector staff can offer, that give them access to things at a lower cost or at better cost as well. So this is going to be a real focus over the course of the next year or so, while we are living with high inflation. And the board will hear more from us, I think, as we start to get some of these schemes firmed up and rolled out as well. But it's been some great work by that group, and thanks, Leslie, for highlighting it.
Great. And the Silver Award is really encouraging, particularly in terms of making a reality out of the, as you say, the work that we're doing as an anchor institution and the support that we're providing to people to come into the organisation. Any other questions or comments on that? Okay, thanks, Leslie, and I hope everything is as good as it can be given the circumstances. But
thank you.
Okay, Leslie mentioned the gender pay gap report that we receive at board and is on the agenda next. Alan, do you want to introduce that?
Sure. So afternoon, everyone. As you'll see by the report was written by Claire and Tool and Remy, who sadly are no longer with us, off to better and other things, I think, and Bart's Health and other places. So I'm looking after the EDI team until the CPO comes on board. So I'm here to report on the gender pay gap report. I think the key messages are that there's been modest improvements for both the two KPIs in relation to the gender pay gap, the mean measure and the median measure. So we've had constant improvement in relation to the work since 2017. That said, you'll see also in the paper that we're probably in the lower quartile in relation to the gender pay gap stats in comparison to other NHS organisations. So there's still a lot of work to do. But nonetheless, hopefully you've seen in the paper there's some good work that's ongoing, and maybe we'll see the benefits of that in the coming years. There's two main factors, as always, with respect to the gender pay gap in the NHS, and they're no different from other organisations. The two things really are the Clinical Excellence Awards when it comes to the bonus payment measure. So we know that historically and traditionally, because of the configuration of medical staff, that there's more males who have Clinical Excellence Awards or paid Clinical Excellence Awards through that process. However, last year we did do the equal distribution of the Clinical Excellence Awards. So there's no competitive process. There was an agreement across the UK that we would just share the money to all consultants, and in essence thanking them for the work that they've done during the COVID period. So that's had some impact in the median figure. So that's quite positive. The other factor is where we still score quite poorly is in relation to senior leaders in the organisation and senior female leaders in the organisation. So particularly around the VSM aspect. You'll see in the paper that, again, in the comparison around some of the bandings, we're doing well with respect to 8As, which is good for the pipeline. And we've got some high numbers in other higher grades, such as band 9s, etc. But it's really the aspect around the VSM where we're still got some quite challenges. And I think the aspect for that is, although we've got quite high numbers of the band 9, that's normally in the clinical areas. So we know that the triumvirate teams are set at the band 9s, and their access into the corporate or VSM roles are perhaps more limited than looking for external applicants or others within the corporate teams. So it's something we need to think about how we try and recruit into those posts. And again, whether or not through the careers mapping that we're doing about how we can transfer skills from the clinical areas into the more senior roles in the organisation. So we're looking at the activity that we're doing around the senior recruitment, which we're reporting on at PCC. I will feed back in relation to, hopefully once we've appointed the CPO, about some of the work that we've done there, because it's been quite useful about having conversations with the applicants in relation to, and it's noted in the paper, about flexible working and all those aspects that have come out of the paper about what we need to do to enthuse people to come and work here. So I think one of the key things is working with the headhunters and having early conversations with prospective applicants about some of the opportunities that we do offer and will offer as part of the recruitment package for senior staff come into the organisation. So it's things like that we need to work on and keep that in mind when we're looking at it. I think one of the key aspects is the Women's Network. We've got 2 chairs who are really proactive and want to do some real deep dive into some of the aspects, particularly around the clinical piece. And I think, Jackie, you and the MPs met with them and had they really welcomed your attendance and thought it was a really positive message to send out to women working in the organisation. So that was really good. But nonetheless, they're sort of struggling for some support and capability elsewhere to support with this work. And again, it's been looking at what's happening in BHRUT, because BHRUT are in a better position to us. The gender pay gap is much better than ourselves. And some of the work that they've done, we're looking at the learning there. They've set up specifically a task and finish group on the gender pay gap. So not just relying on the networks to see this work through, but to sort of lead on this work and supporting the networks, I think will be quite key to that. So we'll be looking to set something similar up in the organisation so we can support the two chairs within the Women's Network. And that will be a resource for myself and elsewhere about what we can look at and what we can do in relation to that. So I think there's still work to be done. I think we've got some good ideas about where we need to go next. Specifically, I think targeting the key aspects in the relation to senior recruitment into the organisation. But as I say, we'll get some good learning, I think, from BARTS, and collaborating with them will be really positive work. And certainly I know that they're coming over more often to support the women's network here.
Thank you, Alan. Of course, the fact that the Clinical Excellence Awards have been distributed on the basis of a sort of fair shares approach during the course of the pandemic, and we have managed to close the gender pay gap, is pretty conclusive proof of what I've always believed, which is that Clinical Excellence Awards embed gender discrimination in the pay system of the NHS, and it's just not good enough. And I think that has to change, because we've got the proof, if we needed it, that that is the case. And that's not because, I don't believe that that is only because of the structural situation with respect to clinical staff, because if that was the case, it wouldn't have got better when you did it on the basis of everybody getting one. It's because, frankly, male clinicians are more likely to apply, and to apply for higher awards, than female clinicians are. Secondly, on this point about the staff network, I think the staff network has done really, really good work in highlighting this. But you're right, Alan, that we can't leave it to staff networks alone. And to go back to what I was saying previously about collaboration by default, it's really good that there's been this collaboration with the BARTS Women's Staff Network. But we need to go further than that in supporting change in order to ensure that we're making quicker progress, which is really good. And I thought the other point in the report about the significance of flexible working and other ways of enabling people to both work and get promoted is going to be really important in helping to close the gap as well. Marta.
Thanks. You stole some of the comments I was going to make, Jackie, particularly with the Clinical Excellence Awards. I didn't quite understand them, how they
quite irritated about it, Marta.
Sorry, I didn't quite understand how they came about. It was interesting to hear your comment. And I suppose, yes, sharing them equally in the past year has shown up some really interesting things, but the fact is they're likely to go back to the way in which they were done in the past. And therefore, I think my challenge to the team is, so what are we going to do to encourage our female clinicians and our female staff, who we think as an organisation should be applying for these awards, to help them apply for these awards? You know, because I agree with you, Jackie. I think, or maybe it was Alan that said, I mean, men tend to put themselves forward, whereas women tend to think, well, I haven't quite got there yet. And it's not just a network issue, it's a leadership issue. So I think I would like to understand from a leadership perspective, what are we doing about talent spotting and encouraging and supporting particularly female staff, but also male staff. But, you know, I think the emphasis here clearly from this report is what is happening with our female staff and what are we doing to support them. Thank you.
Thank you, Marta. Caroline?
I think you should never follow on after Jackie and Marta, otherwise all what you want to say is encapsulated really neatly. But one of the things I'd like to pick up on is, Alan, your comments around working with the staff networks. And I think working in that partnership way, not putting all the responsibility, it's not all incumbent on them to do everything, but working in partnership. So, you know, you've got the leadership, you know, from the trust, you know, you've got some of the initiatives, but then enabling through this partnership approach to work on the higher value items and really, you know, leverage, you know, the good work of the networks in the best possible way without negating responsibility. If you can hand over too much responsibility to the networks without that partnership, it can actually do less for the trust that they have in the organisation, because they feel that they are having to take all the initiative and there's no will. Thank you.
Thanks, Caroline. Sue?
Thank you, Jackie. In addition to everyone else's comments, I would quite like to see a focus on our recruitment practices. There's a wealth of knowledge out there about the psychological approaches to recruitment, the language we use, all of those aspects that will encourage more women to apply. I think our problem is a lack of pipeline often. When I interview at consultant interviews, there's hardly any female candidates. So it's not just about making a better offer for them, it's about helping them to think that they would like to work for us through our use of language, placing of adverts. So Alan, if there is something that could go in there on actions around recruitment practice, I would find that very encouraging. Thank you.
Good. Leslie?
I think in addition to what Marta said, I think it links back to the work in the leadership strategy, which is around creating the right culture in the organisation. And that's some of what Alan said, because at the moment, and the Women's Network will say this, women don't feel, there is a lot of misogyny in the organisation, and women don't feel that it's very easy, or that they're going to have a very easy time if they do go for senior posts, particularly in the medical areas. So I think there's an awful lot to do in terms of leadership, because at the moment, 1 or 2 women coming into a very uncomfortable culture isn't encouraging at all. So I think, and I know I get a bit boring about saying this, but fundamentally, the issue is one of creating a culture where people actually feel supported, whether they're man or woman or what ethnicity they are, because at the moment that isn't the case within the organisation. And we need to get that bit right. Otherwise, what we're doing is putting people in positions which are incredibly difficult without the right level of support. So the work we're doing with the King's Fund and the work we're doing on leadership, I think, is incredibly important in that. And the work we're doing in recruitment, in terms of making sure that we've got enough women coming through into senior positions, has got to back that up. But there is a real issue with the culture of the organisation, and one that needs addressing, and that's what the leadership and talent element of the people strategy is focused on.
That's really important, Leslie, I think. So thank you for that. Anne?
Yeah, thank you, Chair. And this will build on Leslie's comments, but it's just to respond to Marta in terms of what can we be doing to encourage women to apply for those additional payments. And this comes from my experience of working in a commercial healthcare company a few jobs back, where the gender pay gap report first came out, and our gender pay gap was 45%. So I went to see the chief executive about it and came out of that meeting with him basically telling me I needed to sort it out. So not the great chief exec. I'm glad to say our chief exec is different. And I think that is actually one of the key points, that as leaders in the organisation, we need to be really articulating why this isn't good enough, and starting to demonstrate some real action and some real challenge about this. So leadership is important. Leslie's points about strategy and the leadership development strategy is absolutely spot on. And these are the types of things that we need to be including in the work with King's Fund and others as we develop future leaders, and potentially talent spotting and targeting some of those female leaders. At the same time, we need to be making sure that the processes are right. But I'll leave that to Alan to come back to in terms of process. But also starting to really develop some other development opportunities as well, in the same way that I know the Nursing Directorate does incredibly well, as they start to provide temporary opportunities and development opportunities for staff to look at those more senior roles. And those things together really start to create an environment where people feel as if they are then able to apply for those positions. So it's the continued alignment of strategy, leadership and culture that we need to be focusing upon.
Good, thank you. Alan?
Sorry, I think again.
Sorry, Alan, do you want to round up at the end, or?
Yes, yeah.
Yes, okay, fine. You round up at the end then. So let's do Mamta and Linda, and then I'll come to you, Alan. Thanks. Mamta.
Just in terms of consultants, I don't know if you can see the back of my room, but we're looking at consultant appointments and what that AAC panel needs to look like and what the shortlisting needs to be. Then I know a lot of my execs members, including Jackie, has volunteered to do the consultant induction for the new consultants. This is about talking about the new ways of BHRUT, and I know Anne and Jackie and Matthew are keen to be part of it. It's in the 3rd week of September. We're going to run a big cohort for the first time, but then run it every 6 months for about 12, 13 people. We're going to show them new ways of working rather than being indoctrinated with the current culture. We are looking at, so I worked with Sarah DeFritis at BART, Jackie, around the gender pay gap. And yesterday, the Women's Network, which is the first one I attended, I'm the exec sponsor. I will be supporting the team at BHRUT as well. And then the culture position, I think there's a lot of work that Anne probably, I thought was going to reference around not just the King's Fund with the EDGECOM, as well as looking at problem resolution around understanding where do we go and how do we hold people accountable, and what that line is, which is non-negotiable. And I think we need to be very explicit about where we go with that and how we will be holding people accountable without a fear of people don't talk to each other here. There are a lot of grievances flying around between each other, and I'm just really surprised. Why aren't we in a room together having conversations? So I think that will take some time, but we are working our way through putting into place structure around some of the things that we can do easily, and then hopefully that will have a longer term impact.
Good. Linda and Ruth, and then Alan. Linda first.
Yeah, thank you, Chair. And it is actually sort of outside the reason I sit on this sort of first part of the board, but I do have an HR background, and I'm very experienced in actually recruitment in local authorities and in the Metropolitan Police. So, you know, I understand what's been talked about. I think there are 2 issues. I mean, one thing that's happened quite commonly now is you take away the names on application forms, so you actually haven't got a clue who they are. So actually that sort of negates everything. But Leslie has said on more than one occasion, not only now, but the misogyny word has come up several times. What are we doing to tackle that? Because if we could tackle that, then some of the other things, some of the more positive things you're doing to encourage women to apply for jobs would actually be partially removed. Because if there continues to be misogyny with the large numbers of men that are in the more senior positions, then all of the good work that you do over a very lengthy period of time is actually going to be negated. So I just wonder whether or not flipping it would actually be about what are you doing to tackle the perceived or maybe real misogyny that is there, because there's 2 halves to the same coin here. And I think that is something you maybe need to look at. Apologies if I've overstepped my remit here.
Thank you, Linda. That's exactly what that's one of the things we reference when we talk about culture. So when we're feeling less pissed off with everything, we call it changing culture. When we're feeling pissed off with everything, we call it misogyny. There we go. Ruth.
That tickled me. I think just to reference back to Linda, I think there is a change of feel. I think that the change of leadership is definitely shown, and kind of Matthew's letter to all the staff, I think, is very encouraging. And things I've heard from female members of staff is that they're incredibly encouraged by that, and I think it is being backed up by actions. I think unfortunately you still get the perception, even when actions have been taken for a time, there's certainly a lag, isn't there, within that. I think the only thing for balance that I wanted to say is what we don't want to suggest is that our male members of staff don't deserve some of these awards. It's more about levelling up rather than bringing any others down. And the other thing I'd really, really recommend to the Women's Network is and it kind of doesn't relate to some of the misogyny. I think there's a lot of male members, just males, who are lacking in the understanding of some of the challenges of women. And women tend to understand women. And some of the outreach that needs to happen is for those women to essentially educate some of our male members of some of those challenges, because it really helps. And I think it does open their eyes, and it stops the divide being quite as wide as it could be. So yeah, it's just make the remark.
That goes for the world, Ruth, not just for BHRUT. But anyway, Alan, over to you.
Good luck, Alan.
Yeah, well, first of all, Ruth, we don't use levelling up anymore after Boris leaving us, okay? So I think even Michael Gove going, so we have to think of another phrase. So I think what most of the feedback was around different bits around what we need to be doing. So the flexible working piece, the talent pipeline piece, all those bits I think we are doing. It's about pulling that together and demonstrating that this report was really reporting on the gender pay gap, but I think there's a lot more going on than we've set out in this paper. So if that's okay, I'd like to come back with the team and demonstrate some of the action plans that we're putting together in relation to some of the things that I mentioned. So I'm quite heartened because I think those are the things that we are doing. I think again from the Clinical Excellence Awards piece, BHRUT have been very bold in what they've done. They did an equal sharing of those who are whole-time and those who are part-time, and I thought it was a really bold thing to do. So it's things like that we need to look at and learn from. So through gritted teeth, it's about learning from our colleagues down in BHRUT about how we do some of this stuff, but they've done really good work there, and MAMTA, obviously coming from there, will help with that. So again, we'll pick that up. I think it was Caroline about the networks. We've had a new head of wellbeing coming in called Sarah Najuma. I don't know if you've met her yet. She is really an impressive EDI expert. And she, again, was feeding back to us about her perceptions over the past 4 weeks she's been here. And again, it's about how we use and work with the networks. So that sort of clearer understanding about what we should be doing to support them rather than just listening about the concerns that are coming up. So myself and Matthew had a conversation with her this week and last week around the BAME network, which we set us some challenges. So I think with her coming in has been really positive, and again, we're learning from her about how we do those things. So a lot of good things are happening. So if I may, we will come back at another point in time and go through the actions, and we can track that and monitor the key bits. And I think there's certain bits and pieces that we need to be working on, which I think you've all identified. So thank you.
Thank you, Alan. Matthew? Oh, you put
yeah. I think Alan sort of picked up some of it, Jackie. But I suppose there's a couple of things. I mean, we've talked a bit about misogyny there, and we know from our staff survey that we've got an issue with racism as well. There's very much there. I mean, we're a very diverse trust with one of the most diverse workforces in the country. And I suppose what I find fascinating here is that actually, in the NHS, occasionally I think we're a little bit binary about diversity, as in all diversity is a good thing and any kind of monolithic culture is a bad thing. I suppose what we don't also consider sometimes is the challenges that having multiple different cultures coming together does bring with that as well. And I think some of what we're trying to do at the minute is to create space for people to be confident to talk about these issues in the first place, because I think understanding what's going on is important, and giving people who've been here for years and in the NHS for years and who've experienced problems with discrimination because of elements of who they are, they first need the courage to be able to speak about it. But then what they do need to see is an organisational response. And, it's kind of easy to do the kind of, I mean, I was very struck during the Black Lives Matter thing. I didn't tweet about that because I saw a lot of white men in shirts tweeting virtuous things about Black Lives Matter. Actually, I was working with a colleague at the time who'd been in the Met who said, well, we saw all this around Stephen Lawrence, but it didn't necessarily stick. And I think actually what you really need to do is start to take apart some of the mechanisms that make the place run and think about the sustainability of this. And in the conversations we've had with the people who are looking for the Chief People Officer candidate, and Alan's already doing a lot of this work with staff side and the networks as well, is to look at how you recruit people. It's to look at, once people are in the organisation, how they get access to opportunities, who gets the temporary promotions, because the people that get the TPs get the promotions in due course, who gets to go on training courses and do the exciting stuff. And actually there's some interesting dynamics around different teams when you look at that, and who seizes those opportunities. It's also looking at what you do when people leave as well. I mean, I've had 2 one-to-one leaving conversations with people this week. Both members of staff who I passed in the corridor and had a chat with, and they said, oh, I'm leaving shortly. And I said, well, come and have a chat with me, because they mentioned a couple of things about it. And it's how do we talk to people when they've decided to leave the organisation and find out what the motivation was? And how do we feed that back into things that we're doing? Some of them were hoping to, I think both of them actually, we can probably persuade to come back. actually once they've got their breath somewhere else and recovered a little as well. So it's not just about saying the right things in terms of the culture. It's about then changing the fundamental mechanisms which allow people to enter and progress through the organisation. Part of that is aspiration. If you can't see anyone on the most senior team in the organisation who looks like you will not believe there are aspirational routes for you to succeed within the organisation, and that's very important for the diversity of this board and this executive team. And part of it is the encouragement that people get from managers as well. And Alan and Anne and Mamta and I were very fortunate to go to the Staff Side Away Day. Was that this week or last week? I've lost track. Was it last week? Okay. The weekends disappear, don't they? You know, we had a really good conversation with them actually about some of the things that we're trying to do around this. You know, they talked about the grievance process, but you know, as Mamta says, we escalate things to grievance. There's a lot of very twitchiness about the culture in this organisation. We need to help people calm some of it down, but really to improve some of the quality of our management, because lots of the problems we have are around management capability. And I can say things, the exec team can say things, but actually the vast majority of our staff are managed by band 7s. Actually, and if we don't provide the right support to people in band 7 to understand what being a leader is and what being a good manager of people is, we will never crack this stuff. And actually, if those of us in this board want to leave an enduring legacy at this place, the biggest thing we can probably do is really raise the quality of the people that manage the majority of our services and put the right structures around them to make a more positive culture endemic in the place rather than sporadic as it currently is.
Good. And thank you for your leadership on this, Matthew, which is very important. Let us move on to finance and operational performance. And we've got the committee report first, and Mahbub, you will present.
Thank you very much, Jackie. To start off the report, I'm just going to say I could use up the whole 10 minutes speaking to the report, but what I'll try and do is just skim over some of the headlines so that we've got time and space to have a conversation around these. And it's helpful to be made aware with early insight in month 2 that we are off plan. I mean, it's not good to be off plan, but it's even worse to find out you're off plan in month 5 or 6, as has happened in the past. What we are aware of are the underlying factors which are around pay premium, security and rental of space for neurosurgery and orthopedics. But if I can talk about the kind of tone and the culture of the meeting, having early insight and a good understanding of the underlying issues was really welcomed by the committee. And then with Matthew, Fiona, Caroline, Anne and Alan collectively taking ownership and providing assurance around grip and control was a welcome change, certainly from my perspective, and bringing forward an idea that modelling around the design of the national systems oversight framework to be used as to categorise the areas that we need to focus on in order to bring forward robust recovery plans. That's in paragraph 1.8 of the report, and it kind of highlights that the area in category 4 is estates because of the overspend on security. And Matthew mentioned security in his chief exec's report at the start of the meeting. And I do believe that we need to delve further into this, because our security costs are also because we are providing essential services for those with mental health problems, which should be better provided elsewhere in the system. There's a system-wide response to that needed, but there's also a requirement about where the system funding could be shifted quicker than the system actual in terms of service provision. Then the other area in category 3 is around cancer, clinical support and surgery. And Matthew made it clear that this is about linking consequences to actions as rewards and privileges for achieving targets and outcomes. And there's also the opposite, which would mean a tighter focus on and a restraint on some freedoms that areas may currently enjoy. I'll just stop there, because before I go into the bits of detail, say if Matthew and colleagues just want to add to this important different way of working that's been adopted.
Matthew.
Thanks, Mahbub. And this is we had a really good discussion with all the senior division leads actually about this. You know, people recognise the real need to get into get our teeth into this. And I think what we have talked about is, you know, if you can save money and get ahead of your run rate, and you've got business cases you want to support, you know, we'll be inclined to support them. You know, we'll be inclined to help you. And so there's a degree of earned autonomy here from the divisions, whereby if they're doing what they need, you know, we all need to make a contribution to the overall savings target. So there's obviously a slice we've got to take off that so that we deliver what we need to do in terms of the run rate to get out of soft 4. But then there's also a stage beyond that, where if you say to a division, you know, at the minute you are spending X million quid a year on high cost banking agency staff, actually, you've just told us you want to do this service change. If you get this under control, actually you have got the money already within your division to make the changes. And actually, when you look at what we spend globally, the vast majority of the things that we put on the table in terms of transformation could be resolved through us getting to grips with this high cost staffing agenda as well. And I think there's further information in the pack that I think maybe we'll come on to that shows in some, you know, we've seen real positive movement in medical staffing actually in the last month, you know, in terms of us really getting to grips with that through the medical staffing hub and really pushing down some of these very high rates that we've been told we can't get to grips with. And when we can when we do it right and we stick to our guns on it. So I think this concept is all about earned autonomy, encouraging responsibility within the divisions, but doing it through a framework where, you know, we're very clear that we know where people are against the run rate and hold them to account, because this is all about I&E really this year. You know, it's all about getting the I&E into the right place, and we know where the buttons are that we need to press to get stuff under control again.
Thank you for that. And I just want to underline that having a new set of execs working alongside the existing has also added the additional capacity. That's really important to turn those plans into actions and demonstrable outcomes in changes in our financial performance. The next area is just quickly touch upon non-elective recovery. RTT performance we know is sluggish, and we know that some of the consequences of that is the additional payments that patients who were removed and then put back onto ERS. The main focus on this for the next couple of months will be about tackling the large number of patients who have not had their first outpatient appointment. There's obvious advantages of that, not least to have a pipeline of patients for theatres. The other aspects of what we considered was certainly around workforce, and as Matthew said, where a focus has reduced the medical spend on premium, but what we've seen is a sharper shift on the increase on demands for agency premium for nursing, particularly in critical care and ED, and we'll have a look at how we can try and reduce those. But what Alan and colleagues are also doing is not just tackling the stuff that's in their face now, but also filling in our substantive establishment as well, because that we know is the best way to reduce it. And I had a kind of catch up with Hardeep last week, the sort of group director of finance, and asked what had the Barts group done, and it's the same thing, but it's about real focus on every shift, every roster, getting down into the granular detail of making sure that shifts are booked properly, so you kind of reduce the need for more bank and agency staff as well. And I think what we'll be looking at going forward is about the capacity to be able to deal with the current issues, i.e. reducing the high value spend, but also continuing focus to fill those posts. And you know, there are some green shoots. 70 posts were recently filled. And when I've finished speaking, Alan might want to comment on that. And the kind of last area to mention is that we considered several business cases, we approved those, but it's worth highlighting to colleagues that the volatility in construction related activity is hitting our business cases when we go out to procurement, with substantial increase in costs, not just what we're aware of through RPI, but just the availability of labour and materials. We've decided, we made a decision that on digital, we want to have a specific item to bring all of our digital programs together at future FIC meetings, so we can look at the interconnectivity between our digital investments going forward and how we can look at getting the best bang for our buck about those programs, and the delivery of those are also importantly connected by the same teams, the same individuals are leading them, so it makes sense to have a rounded view of our digital improvement programs going forward. And I think the point that Jackie made earlier on, my very last sentence on this report, is the software and the assistance that's needed. I think assistance probably isn't the right word. It's about the peer support of where BARTs have gone through many of these sort of transformational changes that we've embarked upon their learning. We're also providing some of the capacity that they have in their sort of central services. I was impressed would be an understatement. I was wowed by the size of their capacity that they have in their central services of organisational development, their ability to be able to manage large programs at scale. And it's those sort of things that if they were willing to, and I'm sure they are, work with us on sharing some of that capacity, it would really help us in this year. Leave that as an intro, Jackie. Sorry, it went on for a bit, but there was a lot there to talk about.
Okay, thank you. And some of it touches, I think, on the subsequent on the report after next, the finance report as well. But thank you for that. Are there questions and comments on this? Would it be worth, Alan?
I mean, my book's asked me to speak. I don't think there's much more to say about it than your report. I think the life has got easier for me. That's all I'm going to say. I think having the execs around the table working on this has been really, really powerful. It made a huge difference over the past 6 months, and I'm hoping FIC see that. So I think that's all I can say on it. It doesn't feel like we're sort of working alone, and well, not alone, just myself and finance colleagues. Everyone seems to be involved in this just now, and that's just really made us progress this quite well. It's still quite challenging around the workforce and getting that right, but as I say, I think progress has been made because we're all sort of heading in the same direction, which is really positive, actually.
Good. Okay, thank you for that. Thank you for that update. Let's do the integrated performance report. Caroline, I think you're introducing this.
I am, yes. Thanks, Jackie. So the pack that's been circulated is actually the April data. The May data is available and will be circulated after the meeting. And I'll just quickly talk through that. So the May performance for the trust for ED 4 hours was dropped slightly from 59 to 58%. However, our type 1 performance remains stubbornly low at 32%. On the plus side, we've seen a good improvement in our ambulance delays because we've instituted the ambulance receiving centre. And during May, we saw a cumulative total of over 1,700 patients have gone through the ambulance receiving centre, and we'd released over 12,500 hours of time back to LAS. We continue to make good use of the new short stay medical ward that we've opened in Queens, which is Sky A. That's increased our inpatient capacity, which supports our admitted flow position. Also included in the pack are some new metrics around the length of stay for patients in our emergency department. We've seen a reduction in the number of patients spending more than 36 hours in the emergency department. In May, with 125 patients compared to 270 when we first started reporting, which I believe was in January. I think this is an illustration of some of the hidden improvements that we've made over the last 6 months, which is not always visible through the 4-hour target. We're going to add more metrics to this pack over the next couple of months, which, as Mahbub said, will support our exit from SOF 4. So, for example, we'll be looking at the amount of time that patients spend in ED over 12 hours. And we're also going to give you some data around the stay that mental health patients have in our ED, and we'll detail that separately. I'm going to hand over to Fiona now, who's just going to take you through some of the elective performance stats. Thanks, Fiona.
Thanks, Caroline. I'm going to attempt to summarise all the planned care metrics in a neat update for you all. And actually, while I was listening to the finance update, I was struck by the connection between elective recovery and planned care recovery and the SOF 4 and financial recovery. So just to sort of expand that briefly, a lot of our financial recovery is connected to increasing the number of patients we treat and getting the patients' waiting times down to a reasonable number. And in many ways, that's an ideal opportunity for us to improve the quality of the care that we provide to people, improve the access times so patients get seen faster, but also to provide a financial opportunity for the organisation to grow its way out of some of the financial recovery issues. So I'll just talk briefly about the RTT position, which is the 18-week position. And we've not really changed very much, I think it's fair to say, over the last few months. We're hovering around 60%. But we all know that the current focus for all organisations in the NHS is the other end of the waiting list, is the long end of the waiting list, where we're being very specific about how many patients we want to wait a long time. But more importantly, most of our recovery efforts are pointed at that back end of the waiting list. So I think it's probably been said a couple of times already, but we have reduced the patients who've waited 104 weeks. I think it's down to 2 now, which is the latest number. But actually what we're going to do as our next or what we're going to do with our current focus is to really start to focus on all the patients that have waited over 52 weeks. There's in the region of about 1,700 of those, which moves around a bit. And I hope through our recovery activities and a slight change in focus of the work that we're doing on the waiting list, that we'll start to see quite a dramatic reduction in the patients that have waited a long time. I think we'd all agree that waiting 52 weeks for anything in the health service is far too long, and we're all really clear about what we need to do to reduce that. I just wanted to to explain very briefly that we always focus on getting people treated at 52 weeks. We think we need to do more surgery or more treatment of certain kinds, but increasingly across the NHS, and particularly at BHRUT, the patients that are waiting the longest are actually sitting waiting for outpatient appointments. So it's all doable. It's a big mountain to climb, and we're going to have to put increased effort into pointing our resources and our workforce at the bits of the waiting list that have the most challenges. But it's a blended effect. It's not just about surgery, although that's equally as important. Moving through to our diagnostic services, we know we have a legacy backlog in MR and CT with about 2,000 patients in the over 6-week bracket. And that, again, is going to be a focus for recovery action going forward. We have some useful additional capacity coming online with the replacement of existing equipment, which will give us an opportunity to really drive down the waiting list there. And there are 2 areas that we need to improve within DMO1, as we know. One is actually doing the scan, and the second part is reporting it and getting that pathway moving on through the patient's diagnosis and care as appropriate. So we've got about 25% gap on our DMO1, but it's all down to CT and MR, and in many ways that helps us focus on the work ahead. In cancer, I know you've heard recent reports about how well we're doing on cancer, and I have to say I've been really impressed with the commitment and the work that the teams do on a daily basis, finding capacity for new referrals, making sure patients are investigated and receive their diagnosis in a timely way, and obviously making sure that treatment is expedited either within BHRUT or with our treating partners, particularly at BARS. So it's a massively joined up approach. Our performance stats speak for themselves: 94% for 2-week wait, 66 for FDS, and 63% for 62 days. So all really good work. Lots more to do. We never stop with our recovery improvement, and performance around access is particularly pertinent at this moment in time, but I'll probably finish there. Thank you.
Thank you. Are there any questions or comments on this integrated report? Okay, let's move on to the finance report then. Nick. So, yeah, Nick.
Great, thank you, Jackie. May I pass on to Mike, please, Jackie? Thank you, thank you.
Thanks. Afternoon, everyone. I won't repeat, so maybe I'll just add 2 further key points then. So, worth noting that because we're 4 million off plan, we're not currently on track for where we would need to be to exit System Oversight Framework 4. We are tracking that on page 9 of the finance report. So if you have a look at that page, we need to be in the green or the amber zone of that graph. So that's key point 1. Second point is that we believe we've got about £25 million worth of risk in our forecast as things stand. So we know we've got a challenging plan and out of necessity in terms of affordability. We've got 25 million of risk that's due to planning gap and delivery gap. I'll take questions because I think Mahbub and others have covered the money.
Thank you, Mike. Okay, we have covered that. I think people... Sorry?
I'll have to refrain myself in future. I've nicked everyone else's points. Damn it.
It's your prerogative as the chair of the committee. Good. Okay, operational plan, which has obviously had a lot of poring over in various places. Do you just want to update us on where we are with it, Anne? Thank you.
Yes, yeah, thank you, Chair. So yes, I mean this has been brought to the board in very early phases earlier this year, and it's now been through the Trust Executive Committee and through the Finance and Investment Committee as well. So it's here for the final sign off for the by the board. So I just want to make 3 very quick points about it. So the first is that this just provides us with the overall operating context that we are working in. So it does describe the population we serve, it describes the scale and the scope of the services that we provide, and therefore provides that kind of external and strategic guide to the business decisions that we make on a regular basis, and particularly just around the balance of those 5 objectives that we've got there, some of which are tricky to keep in balance, all 5 at once, but that is what we strive for, and I think that today's a good example of us trying to do that. And each of those 5 objectives will have been spoken about in today's meeting by the time we finish. So that's the first piece, just about context. The second piece is about alignment. So it's not just about the board being aligned around all of this, but it's the rest of the organisation as well. So just making sure that this is in a format that is engaging for our staff to understand, and that we have conversations about what it actually means, which is the third and final point, which is just about keeping this live, and we are doing that. So one of the things that we are doing is having a workshop every other month with our leadership teams to dive into each of these objectives. So Matthew referenced the finance one that we had a couple of weeks ago, where we really started to talk about accountability in order to use our resources effectively to become financially fit. So this is something that we will continue to use in our daily conversations, not only in those workshops, but also just in terms of how each of the divisions and each of the specialties start to balance each of those objectives. So none of this should be new to people, most of the people around the table today, because you'll have been involved in developing it. And so we just bring it here for the final approval of the board.
Thank you, Anne, and to everybody who's been involved in getting it to this stage. Is there anything more that anybody wants to say about it? No, good. Okay, thanks very much. Audit and Risk Committee and the review of their terms of reference, and there's been a lot of work, it being that time of year, that the Audit and Risk Committee have done. So thank you very much, everybody, for that. Sue, do you just want to introduce your report?
Of course. The report actually is a little bit behind the curve because I think most of the content has already come to board. So I will take it as read that you are aware we've signed off things like data protection toolkit, etc., and obviously the accounts. So the only item of real substance is to note that we have reviewed our terms of reference and made minor amendments to them, largely to reflect the group structure and the change in accountable officer, but minor tidyings up and nothing else really. And there was one use of the trust seal. Both of those items are under separate reports. So that's my intro. Jackie, back to you.
Good, thank you. I think the only thing I just wanted to say was I noted the ICS internal audit sort of collaboration work, which is all good, and obviously learning from each other is good, but we're of course clear in governance terms that our audit committee makes its own mind up about what it wants to do and reports to this board on what it makes its mind up it wants to do. Good. Anything else on Sue's report, or in fact on the terms of reference or the use of the trust seal? No, good, thank you. In terms of risks identified during the course of the meeting, I don't think there's anything that we don't already have within our risk register. I suppose the discussion that we had about both finance and culture were probably the most substantive in terms of the meeting, but I don't think that requires us to sort of alter our current analysis. We've got, I don't think there's anything that comes under any other business unless anybody thinks differently. No, okay. Questions from the public. We have a question from you, Andy. Far away. I think you're muted, Andy, if you're talking. I could see you a minute ago and now I can't see you.
Can you hear me now?
Can hear you now. Yeah, far
Right.
away.
Yep. There appears to be a remarkable improvement. So well done on the face of it in child deaths. They've dropped to, there's been 55 in the last 3 years, and they appear linked to air pollution. I sent in the detailed stuff some weeks ago. So the 55 in the last 3 years. There's a drop, substantial drop after COVID, which pointed to air pollution being a factor. Academic studies suggest that could be a factor. There's also other issues too. And the last 12 months is a mere 3 deaths, which appears absolutely amazing. It's just your clinical directors, if they've got any views on this, if it is significant, the drop there.
Okay, thank you, Andy. Yeah, Mamta will respond.
Yeah, thank you, Andy. So actually, just looking at the FOIs, I think there were 3 FOIs related to the number of deaths, and they've had differing questions, and therefore it's not like for like. I think there have been pretty much consistent between 50 to 60 deaths per year. But anecdotally, as a pediatrician, Andy, I could tell you the effect of the lockdown has meant that there are less infectious diseases related deaths. So this is related to RSV or influenza A, which you would have normally seen in the under 1-year-olds in pediatric intensive cares. And I'm hoping that the next report that we get for annualized report will demonstrate a reduction in the number of infection related deaths. than as you've suggested that it is only 3. So I don't think that's correct.
Okay, well thank you for that. Just the point of information, it wasn't all deaths, it was ones which I associated with air pollution. It wasn't, I didn't ask for all deaths. So that might be, there might be some confusion there. As Chair, it's with you, well, thank you very much for the reply. It's whether I've put up a tweet about, I'm concerned about no resus cover at King George for a period. Is that okay to discuss that?
You can ask your question, Andy. Yes.
Right. Well, thank you very much for allowing such.
I have to apologise for not following your Twitter feed during the course of the meeting.
Yeah, no, there's absolutely no reason why you should, of course. I mentioned that. So the yes, via freedom of information, it appears that for some years it may still be the case, but there was no resus and other childcare available at King George overnight. Perhaps that's been fixed. Is the board willing to consider? I don't expect a decision now, but consider whether there should be an investigation to see if childcare deteriorated as a consequence.
Matthew.
Yeah, thank you. So other colleagues who've been around longer than me, although there aren't many, still on the exec, I think, but they can correct me if I get this wrong. So I'm aware that during COVID, the the children's emergency department at King George was shut for a period of time. And it was reopened last summer. What we have there is we do have sufficient senior staff on at night to manage a resuscitation if a very unwell child comes in through a walk-in route. Ambulances don't take children to King George's, they bring them to Queen's. So the very sickest children that are picked up by London Ambulance Service wouldn't be expected to be taken to King George's, so they bring them here, and that's the pathway that we've got in place. But if there are children, there are sufficient senior medical staff and sufficient nursing staff on site 24 hours a day at King George to manage a sick child. And actually with the rebuild of the emergency department, when the team there were showing me around, they said they were pleased that we'd created a dedicated space actually to assist us with the management of the very sickest children in there. What we would do if we saw a particularly unwell child, I mean, we've got Sarah on, who's Director of Nursing for the site, we would expect that child to be transferred to Queen's as a priority if it was necessary. So we have got sufficient capacity and skill at King George to manage a child who is that unwell. If they came in through the walk-in route, you wouldn't expect them by ambulance. We could stabilise them, and then our priority would be to transfer them here. I'm conscious that we've got Mamta here, who is a paediatric intensive care doctor, and also Sarah, who's the site director at King George. So I might just ask them just to add 1 or 2 things.
Briefly.
Yeah, so I was just going to add, we have 2 resuscitation trolleys in the paediatric area of ED, so we could, so we could comfortably resuscitate 2 children at once, and we would be able to pull in equipment if we needed to do any more. So we are very well equipped to do it.
Okay, good. Thank you. I hope that's reassured you, Andy.
No, unfortunately, briefly, I'm relying on when the 99 calls were no longer taken to King George at the same time.
So Andy, sorry, that we're not having a debate about this.
Fair enough. Fair enough. I'll pursue it another way. Thank you.
You've had your 2 questions. I think you've had a reassuring response.
No, I'll reply later.
Okay. Peter?
I just think, given that it's an emotive subject, I think we should all be clear for Andy's recording that he's making of this and our recording that it has been made clear to Mr. Walker that it is not correct that we didn't resuscitate children at King George since 2014. All the medical experts have made it very clear that we do have people in place to do that.
Okay.
Your board minutes say at one point, appears for years, you did not have staff at King George, and staff had to be sent from Queen's to King George. It's undeniable. I put it up on my blog. You can see
Andy, the fact that something's on your blog doesn't mean it's undeniable. But I think you have asked the question, we have responded, Peter has made it clear. If you want to follow that up in writing, we'll continue to provide the necessary detail. Okay.
Thank you. Thank you.
All right, thank you. So that brings us to the end of the meeting, and we will finish this public meeting and we will reconvene for the Part 2 board at 3:15. Thanks, everybody.
Thank you.